So regarding how do we monitor fertility at home, we have recently a few technologies that can help, and mainly I'm talking about the ovulation kits. You know, like we have like two things in the couple, like to check their fertility. I'm starting with the female part, and the easier way to pinpoint the ovulation is through the ovulation kits. We have so many ovulation kits in the market, and they are very efficient in detecting exactly the right time for the LS surge. You know that before the ovulation, you have to have an LH surge, and then it peaks, and then you have your ovulation within 24 hours to 36 hours after the peak. So there are two types. One is two lines, like the pregnancy test, or you have one with the smiley face or the flushing face. The flushing face corresponds to the start of the LH surge, and the fixed smiley face will be exactly at the LH peak. That means that this is the right time to start your trying for sexual intercourse at home. So basically, it's always, we say that it's better to have a relation before you're ovulating, as we all know that the sperm can wait for the egg, but the egg doesn't wait for the sperm. The other thing is we have two more signs that we can use to pinpoint ovulation is cervical mucus. Obviously, some women, if they have their cervical mucus around the time of ovulation, this is another indicator for best timing. And the basal body temperature. The basal body temperature has almost gone off like a vogue in this era, and we don't recommend it anymore because it's too much hassle and temperature check every day. So we are left with cervical mucus. Also the pain. When you have pain that you can check at the around the ovulation time, this is an indication that you have ovulated. So this is from the ovulation point of view. Second, you have the applications on your digital phone that can help you to as well, like check your cycles as well as the timing of the ovulation. Regarding the counter part of your male partner, we can have like also a sperm count, easy to do maybe after like a few months or more from trying. It's just a simple test that we can do at a lab or an IVF center, so that we can have like at least a baseline for the spermogram. So once we have documented normal sperm in the spermogram, also documented ovulation as well as good timing, I think it's fair enough to say like we can try for at least 3 to 6 months without the need to see any specialist for that. Okay, this question has also an implication of how old they are and if there is any major risk factors in the history. So if we don't have a major risk factor, such as previously noted sexually transmitted infections, or had a tubal surgery, or had like ovarian cysts removed, or having any surgeries on her ovaries. So basically, we need to know this information if she is younger than 35 or older. So all these counts as a factors to be more at ease to advise the couple when to come and see us. So if all the parameters are okay without previous history, they are both, the couple are both young, we can, as per NHS guidelines and NICE guidelines, we say 1 year of unprotected intercourse, and then if not successful, to come and see us. However, there is a kind of important note to say that the trying should be as consistent as possible for every month, because you cannot say try for 3 months and then then you have like maybe 3 months away for work or for holidays and you didn't manage to try. In that case, we are going back to square one. So I think 1 year of consecutive trying, and the most important thing, around your ovulation time, because a lot of couples are trying not as if like at the right time. However, this is not considered as trying. So please take into consideration the timing of the ovulation as well as the consistency to be consecutive 12 months. In that scenario, then we can see you if you are not successful, because usually 80% of the couple should conceive within the first year of trying. Now, in this question, I would say that back to basics as well. We have a couple, we have a sperm count regarding the male, we have ovulation to take to consider, as well as tubal factor, cervical factor, uterine factors. It's in otherwise healthy couple, we still wouldn't know the uterine anatomy, for example, because a lot of cases that we encounter may have like congenital anomalies in their uterus, which they will not be aware of. So a simple scan would detect this, and also like a 3D scan if there is a suspicion of a congenital anomaly of the uterus. Also, the tubal factor, it's very easy to miss or to forget, especially if someone had I'm not talking about sexually transmitted infection, which is like a very important factor, especially if she has chlamydia. Don't forget that any surgery abdominal can affect this. So if someone has got, like, for example, a ruptured appendix when she was young, or like had a severe pelvic infection in the past, or had previous to cesarean sections, so they are healthy couple, but however, these are like risk factor that we should be able to detect if they are affecting the tubal factor. Also, the general health. If someone, for example, has got a chronically medical condition, it has to be monitored and made sure that she is right at the best performance of this medical condition in remission. For example, if she's got systemic lupus, or she has a major chronic medical condition such as diabetes. So all these factors should be well controlled before starting. I'm stressing also about the smoking habits and alcohol drinking. So all this together, maintaining a healthy, good diet, having reduced the weight to the ideal weight, can contribute in having a successful outcome. So we need to have a round out as what is the best scenario to carry on and allow this trying for a pregnancy to occur, in order to be happy to see the patients after that if they are not successful. Regarding the test, obviously the easiest way is to do a semen analysis. So the semen analysis is a very simple test. Make sure it is 2 to 3 days abstinence. We don't like 10 or 15 days abstinence, or just like 1 day. 2 to 3 days is more than enough. Don't forget with the semen analysis, as it is a dynamic procedure, the sperms are renewed every 3 months. So if someone has really a borderline semen analysis or abnormal semen analysis, make sure that 3 months before that, we will check like if he was in a good condition, or they didn't have, like, for example, like a viral condition, especially corona or anything like this, that could affect the sperm parameter. However, it is advised also, if it is abnormally in one of the parameters, we repeat the semen analysis in 3 months' time so that we can check the trend of this abnormality, whether it is stable or whether it is improving or deteriorating. Regarding the other tests, we have a simple test also. It used to be the hysterosalpingography to test the cavity contour as well as the tubal patency test. As you know, we can do it in 3 ways now. One is the injecting a dye, and this has to be in a radiology department in a hospital setting where we inject a dye and then take several films. However, now we have an easier way to do it. It's called HICOSI. It's a high hysterocontrast sonography, where we inject a foam, like a contrast, in order to check it by ultrasound scan. We can check the contour of the uterus, whether there are any polyps or fibroids inside the cavity, as well as checking the tubal patency. It's very easy, it takes like 10 minutes, and it is an ultrasound based. Obviously, the ultimate, if someone is having a laparoscopy for any other problem, then we can do at the same time inject the dye and check that the dye is passing through the tubes. And this is called a laparoscopy and a dye test. So this is the most important investigations that we start with. Not everyone would have a laparoscopy, for example, at the beginning. However, if there are risk factors, then we ought to investigate sooner and maybe with more in-depth. The straight answer is no. Actually, however, I have to stress that IVF has improved a lot, and the success rate is getting higher and higher. When I started at UCH, like in 2001 till 2003, we were quoting them maybe around 35 and 40% success. However, now it is almost like 50 and above, depending on the age, depending on the circumstances. Egg donation has got like a much more improvement and success rates up to 70% in some clinics. So one thing is always I tell my patients is the term infertility, I stopped using it, because there almost nothing now that we cannot treat through all the options that we have in hand. So infertility as such is only restricted to really major situations, such as, for example, like if someone doesn't have a uterus, for example. So this is considered as infertility. However, anything else should be considered as subfertility, whether in the male or in the female. So as modalities of treatment that we have, I have so many cases who got pregnant by simple follicular monitoring regarding timing of the ovulation and time sexual intercourse. This is the easiest way. Ovulation induction is another way, especially in polycystic ovaries, where we try to induce the follicular stimulation in order to have like 2 to 3 follicles and have also a time sexual intercourse. We can step it up with either like ovulation induction with tablets or with injections. Also, we have the intrauterine insemination. Intrauterine insemination in same-sex couple, obviously, and in women who had, for example, like trouble having a sexual intercourse, so in severe cases of vaginismus, it can be used. Also, in specific cases where it is amenable with a good sperm count and she is young, as well as to improve the chances a little bit more than a natural conception, because in the intrauterine insemination we bypass the cervical mucus and the cervix, and we deposit the semen sample, which is centrifuged and basically made tailored to the parameters that should be done exactly like IVF. However, we put this pellet of sperms, which is highly active and motile and very good number, very close to the opening of the fallopian tubes. We are ensuring at the same time that the female counterpart is having an ovulation, and that the egg is awaiting for these sperms during this intrauterine insemination. It's very easy, simple, cheap, and in some circumstances it works. However, you shouldn't be having like high hopes about a success, for example, from the first time. I always tell my patient it can take like 2-3 times, and that's why in the NHS they can offer even up to 6 cycles of IUI and even 12 cycles. However, this needs motivation, and depending on if you are willing to accept the smaller chances of getting pregnant than IVF. The IVF is not, I don't want to label it as the last resort. However, it could be the first resort in specifically indicated cases, especially taking into consideration that it gives you the highest chance of success in most of the cases in a shortest period of time. So the only advantage of IVF is to approximate things and make things happen at in a very short time with a higher success rate. And the only reason why is that we create embryos. So once we create embryos, a lot of hurdles are being bypassed, and we know that we have almost achieved the last step before getting pregnant, which is the implantation. So as in to round up, is the IVF the only option? No, but in some situation is the only option, and we have to accept this. However, there are lots of other modalities, as I have explained, that can basically be tailored to the need of every couple. However, I have to stress that not every modality suits all couples. So there is no one treatment for everyone. And please don't be worried to check with one of the specialists in order to discuss your options, and first having a discussion around what would be the best plan for you.